When considering treatment options for this patient, number one, I want to make sure that she's fully recovered from her surgical resection. I presume that the patient went on to surgical resection likely because she had a neuroobstructing tumor, and as a result, that would be the most beneficial way to address this at the time. But now, if the patient is healed appropriately, I would consider initiating chemotherapy, and it would also be with a targeted agent. Now, she has a left-sided tumor and she is RAS mutant, so unfortunately, because of the RAS mutation, she would not benefit from anti-EGFR therapy in the treatment-naive setting. So I believe this patient went on to receive FOLFOX and bevacizumab, which is a very reasonable option, but one of the other treatment options I would like to consider is FOLFIRI as well. That's another option for the patient. But for a 38-year-old patient with good performance status of 0, I do like to be extremely aggressive. I am a big advocate of the FOLFOXIRI regimen, which is basically irinotecan, oxaliplatin, 5-FU, all together in one combination. It's a very high response rate, and I think it's very reasonable for a patient that's young with a good performance status. This is largely based upon the TRIBE trial, and that, once again, would be combined with bevacizumab or Avastin. The way that I would normally provide it to that patient is I would do 6 months of FOLFOXIRI, and then following the 6 months of therapy, or at least until, as long as there's no neuropathy, then I would go on a maintenance chemotherapy. But in this case, this woman has opted for FOLFOX plus Avastin, which may be the case because some individuals do not like to have the potential hair loss, and irinotecan will result in hair loss. So FOLFOX Avastin is a very reasonable regimen. I would just recommend that the patient be followed closely just because the risk of neuropathy, which usually occurs after the 3rd month. If that was the case, then I would remove the oxaliplatin or reduce the dose of the oxaliplatin to prevent or reduce the development of neuropathy, and then move on to maintenance chemotherapy. It sounds like as if she has unresectable disease, so it is unlikely that surgical resection of the liver would be feasible, especially if it's bilobar. Other treatment options, as I mentioned, could be FOLFIRI plus Avastin, actually, which is one of my other favorite regimens. I believe it's tolerated extremely well, and excluding the hair loss, other than that, I think patients can be on it for a very prolonged period. So those would be the 3 potential options for a left-sided RAS mutant tumor: FOLFOX, FOLFIRI, or FOLFOXIRI if the patient has good performance status, and that would all be combined with bevacizumab. So the expected outcomes for a patient on FOLFOX and bevacizumab, it's likely that the progression-free survival will be anywhere from 10 to 12 months. And as I mentioned earlier, if possible, as long as the patient has stable disease or is responding and is tolerating the treatment well, I would go on to maintenance chemotherapy. And at some point, if the disease it appears to be progressing again and there's no evidence of significant neuropathy, then I would reintroduce back the oxaliplatin-based therapy, if possible. Otherwise, I would have to switch her out to FOLFIRI. If the patient had an all RAS wild-type tumor, and I presume also BRAF wild-type tumor, some other options would include not only FOLFIRI, FOLFOX, or FOLFOXIRI, but instead of using bevacizumab, you could consider anti-EGFR therapy such as cetuximab or panitumumab. Although I would not necessarily advocate for FOLFOXIRI plus anti-EGFR therapy up front at this time. There's very little data in the treatment-naive setting, and there was a small study that I apologize, I can't recall the name of the study, but it was a small study of less than 100 patients, and it didn't note any improvement in progression-free survival versus just standard treatment with FOLFOXIRI. So, and there's obviously be a lot of significant toxicities because FOLFOXIRI can cause myelosuppression, and EGFR therapy causes significant rash. In that case, in an all RAS wild-type patient, I would probably favor FOLFIRI, FOLFOX, or FOLFOXIRI with Bev, or if we're considering anti-EGFR therapy, FOLFOX plus Bev or FOLFIRI. I'm sorry, FOLFOX plus anti-EGFR therapy, or FOLFIRI plus anti-EGFR therapy. For any patient on FOLFOX plus bevacizumab, we would highly encourage maintenance chemotherapy because oxaliplatin may result in neuropathy after approximately 3 months of treatment. And you would continue the maintenance chemotherapy until there's evidence of progression of disease, and then just resume the oxaliplatin as long as they don't have any significant neuropathy. So in this patient that is RAS mutated, left-sided tumor, started on FOLFOX plus bevacizumab, your next treatment option would be FOLFIRI plus bevacizumab. That would be your next best treatment option off study or a clinical trial if available. We always encourage clinical trial enrollment if possible.